All right. Well, let's keep marching through. We're up to our last session, our last section, I guess. And kicking things off is going to be Dr. Laura Diegelmann. Laura was a graduate of our program in 2010 and did an ultrasound fellowship soon thereafter. And actually, Laura's done a handful of interesting things since her graduation. So, Laura, before you get started talking about lung ultrasound findings, can you just recap us on where you've been and what you've been doing since 2010?
Yeah, I can't believe it's been 10 years, but it's always good to see some familiar faces. So hello, everybody. Like Amal said, I finished in 2010. I moved to Australia, Queensland, Australia, where I worked for CareFlight and did a fellowship in aeromedical retrieval. I realized in the middle of the outback, I did not have a CAT scanner or a chest x-ray, so I wanted to get more proficient at ultrasound, so I returned and did an ultrasound fellowship. Wanted to get a little bit of research under my belt, so I moved to Cape Town, South Africa, and did an ultrasound research fellowship. I worked on the SHOCKED trial, which looked at sepsis with ultrasound, and that was at a Kailita District Hospital. And then I returned to Baltimore, and now for the past 3 years, I've been at Inova Fairfax in Northern Virginia, working as a nocturnist, so in the emergency department. So I do appreciate the later time slot this morning. 7:30 or 8 would not have worked out too well. But I wanted to talk about a little bit of ultrasound findings that we've seen in COVID. Just a brief recap of the basics. Make sure you know the difference between A lines, B lines. A lines are normally seen. They originate in a parallel distribution from the pleural line. They're equidistant apart, whereas B lines, seeing 1 or 2 are normal, seeing more than 3 or confluent B lines are abnormal. And they originate in a perpendicular fashion from the pleural line. I'm going to divide the lung findings that we see or that have been reported into the different stages of the disease process. Most of these findings were out of small studies that were done in China. And then one is a firsthand account by Dr. Chen, who's a Madrid physician who documented his own ultrasound findings on Twitter. So I'll have a little bit more of that. Oops. Okay, so early you see patchy or focal B lines. That's from the increased edema, and you start to see thickening and irregularity of the pleural line. And what that looks like, the left picture is the B lines. They're not confluent, they're still focal. You'll see several within a rib space, and if you were to have gotten a CT scan, you might see some ground glass opacities, or on a chest x-ray, could be completely normal, or you could see some patchy infiltrates. Most likely the lung exam, if you're going to auscultate, you would hear like a clear lung exam and the patient may have mild symptoms or no symptoms at all. This would be an example of the regularity that you might see of the pleural line. It's disrupted. You might call it a little hyperechoic at this point, but mostly the disruption is what you see in this picture. In the intermediate stage of COVID, you'll see increased thickening of the pleural line, and then it also becomes more prominent, more hyperechoic. You're also going to start to see some confluent B lines. They're going to start to have like a waterfall appearance and start joining together. This is a great video. This is scanning in the posterior chest, starting at the base of the lung, scanning up towards the apex. And in the first part of the video, you'll see more confluent B lines. They obliterate the A lines, kind of more of a waterfall appearance. And then as you scan up, you start to see the emergence of the normal A lines again and less B lines. Typically, COVID lung findings are going to be in the posterior and inferior lung fields. Also, what you might notice in this short clip is you start to see some isolated pleural effusions, not diffuse, but more of like isolated over the area of the lung findings. Here's an example of the hyperechoic thickened pleural line, B lines that are joining together. If you were looking at a CT scan, the top 2 pictures are 48 hours before the bottom 2 pictures. and you just see increase in a number of the ground glass opacities. You also see kind of more consolidation. And again, it's in the posterior and kind of towards the base of the lungs. Late findings, you're going to see smaller areas of consolidation. They're going to be increased in number. Most of these are going to be subpleural, so they're going to be very close to the pleural line, which is good because that's about all you're going to be able to see with ultrasound. You're not going to see any of the deeper structures if there's more of a central pneumonia. And B lines, again, are going to increase maybe to the point of a whiteout appearance on ultrasound. Here on the left is the irregular pleural line, and you start to see some of those subpleural consolidations. They're going to be very superficial. That's the typical distribution that we're seeing. You also might start seeing some air bronchograms and even what's called hepatization of the lung tissue, where it starts to really look like the liver if the consolidation is larger. And then after the infection resolves, you'll have return of the A lines. If you do see a more diffuse pleural effusion, as opposed to just like an isolated pleural effusion, or you see isolated lobar consolidation, that's really not typical of what we're seeing with this viral pneumonia pattern in COVID. You want to think of an alternative diagnosis or possibly even a secondary bacterial infection in the setting of COVID. If you have made the decision to scan the patient, go ahead and take a look at the heart. Maybe look for other signs. If the lungs look completely normal on your scan, you maybe look at the RV, see if it's dilated, maybe a PE could be suggested. Or there are some cardiac manifestations that are being seen in COVID. I'm not going to go into them, but you could check out the LV for viral myocarditis. Even look at the RV in case the patients develop some pulmonary hypertension from hypoxemia. I'm not advocating ultrasounding every single patient, but if you want to use it as a triage mechanism, if you want to avoid doing a chest x-ray or CAT scan, ultrasound could be helpful. I know the ultrasound cord, at least on the machine that we use, is much longer than my stethoscope, so I'm able to stand a little bit further away from the patient, which is kind of more enticing these days. And then also, if you're trying to make a decision about where to admit the patient, you could use ultrasound for risk stratification. Of course, there's advantages and limitations. If we're seeing patients that are going to be in the emergency department for quite a long time, say for example, they're hypoxic and you want to prone them, you could check out your lung recruitment maneuvers, see if that's improving by using ultrasound. If you do have a handheld machine, at one of our off-sites, we use the Nanomax, which easily fits into a bag. I can keep the whole thing clean. So that's very helpful to use as opposed to some of the larger, less portable machines. Those will be difficult to clean, so keep that in mind. If you're not going to have the patient leave the unit to go, leave the emergency department to go to the radiology suite, you're decreasing the amount of people the patient's exposing. You're also going to decrease contamination of the radiology suite, which may be helpful. We have an off-site emergency department that uses the same CT X-ray radiology suite, and if I send the patient over to X-ray, since we only have one room, it takes a while to clean the room to get it up and ready to reuse. So ultrasound would be helpful if I'm trying to make a decision about my patient disposition. But just keep in mind that it does keep you in the room a little bit longer to do the images, and then you can't clean the machine if you don't have something that you can completely cover. This is the Twitter account of Dr. Chen. He's the physician in Madrid. I'd recommend everyone checking out his images. He documented his lung findings starting with day 1 of diagnosis all the way to day 20 when he finally tested negative. It wasn't like a progressive ultrasound findings. He kind of had a waxing and waning of his findings. Some days he would improve and then get a little worse. He would develop more symptoms, and he said he could even correlate how he was going to feel that day with what his ultrasound looked like, which I found very interesting. And then it wasn't until about 3 weeks after he finally tested negative that was in the normal lung sliding, which I thought was interesting as well. So in summary, focus on the posterior and lower lobes. It's going to be the viral pneumonia picture that we've all kind of seen during residency in your routine scanning. Think of alternative diagnosis if you see something that doesn't quite fit the picture. And then really only use it if it's going to change your management, and always assess the risk versus benefit for ultrasound. So thanks very much. Happy to answer any questions if there are some.
Yeah, fantastic, Laura. Thanks. Any questions out there about the ultrasound findings? Laura, I just have a quick question. Do you know if anyone has actually made a formal comparison of ultrasound versus chest X-ray for COVID specifically?
I have seen some, they were doing some diagrams comparing chest X-rays to ultrasounds. It wasn't, I didn't see an official study, just more of some comments. I think I have it here in my references. One of these studies did look at some ultrasound findings that were seen and compared it to the X-rays. And some of the X-rays were completely normal when they started to see initial ultrasound findings. So it wasn't really like an official comparison, but they just made some comments about the differences in what they were seeing with CT versus ultrasound.
Yeah, a couple comments on the chat line about how amazing it is what ultrasound is capable of doing in, I'll specify, in the right hands, not in my hands, but in the right hands. It's quite amazing. So, well, great. All right, any other last questions?
I have a
Gordo, do you have a question? Go ahead.
So thank you. That was a great talk. Outside of kind of the lung findings, I'm wondering, we're trying to be somewhat careful with how we fluid resuscitate these patients. And a lot of times they either have really large respiratory drives, so they're going to have a collapsible IVC, or they're requiring high PEEPs on the vent. So all of those kind of mess up a lot. And they have a viral pneumonia picture. They already have B-lines in the lungs. So how have you been using, or have you been using ultrasound to kind of evaluate your fluid tolerance in these patients?
So at the main hospital I work in, we just have a larger machine. I have not been using that to go into the rooms. Number one, because I don't feel comfortable completely deconning it. And number two, I'm trying to keep the patients relatively dry anyway. So yeah, I know I'm going to see B-lines on the ultrasound of the lungs. And even if they are volume depleted, even if I give them fluids in the emergency department, as soon as they get up to the floor, our hospitalists and our ICU docs are actually giving them Lasix. So I have not been using ultrasound in our main emergency department to assess volume status. I've just been using it at our offsites, like I said, where we have the smaller portable machine that I'm able to decontaminate more efficiently. But yes, it is a good way to check volume status, but I know at least with our intensivists, they're encouraging us to keep our patients very dry. And if we are going to be adding on antibiotics, that just use the fluids with the antibiotics alone as our volume resuscitation and not give the additional fluids.
Great, thanks.
Quick question. Do we know if these ultrasound findings actually correlate to severity of disease? And then especially kind of what you were saying earlier, when these patients will have like a normal, relatively normal x-ray, but have these pretty significant ultrasound findings, if that kind of portends to a worse prognosis, or if it's just kind of like one of those interesting things about this weird disease process that we're all experiencing.
I think some of the late findings certainly are going to correlate with the severity of symptoms. The Twitter account of Dr. Chen, initially in his first couple of days after diagnosis, he also makes comments about his symptoms. I thought that was very interesting because he would have lung pathology, he would see effusions, or he would see B-lines, and he would have like no shortness of breath. And he said he even used the digital stethoscope to auscultate his lungs, and he had no lung findings whatsoever on his exam, but he did have the ultrasound findings. So you were seeing stuff with ultrasound way sooner than you were developing clinical symptoms. And then as well as chest x-rays, some reports were that they were completely normal when you still were seeing lung pathology. So in terms of like its overall, like what you're seeing in assessing like disease severity, I haven't seen any like published data on that. There could be some, But certainly the late findings are having a worse prognosis, because my guess is those patients are probably already prone to possibly intubated.
All right, well, fantastic. Let's